Very good afternoon to everyone. किसके अंदर है? तो ये क्या है? किसके अंदर है? Okay. It's very important. It's 5 minutes. I'm not sure if that was the time given to you. I hope it is. We cannot change the presenting author. In case there's a change, you can present, but you can't be judged for the prize. And of course, membership, you should be a ratified member. And if you're not, then again, you can present, but you can't be considered for the prize. And if there are any absentees, just clearly mark in your score sheets as absent. And okay. To the first presenter, and I request that most of you know the sequence. So when I call out, I'll be calling the second presenter as well to be ready. So the first presenter is Dr. Pooja Kamar. And
none of the authors have any financial disclosures. So we have been working on lysyl oxidase and its role in keratoconus since 2010. And over the years, we do have proven that in keratoconic eyes compared to that of controls, the lysyl oxidase levels is on the lower side. And with increasing
can we have no talk in the hall, please? Sorry.
The lysyl oxidase levels reduced. Not only that, but if the lysyl oxidase levels are on the lower side, there is higher risk of progression post cross-linking. And also patients with a seemingly healthy topography and biomechanics, if they undergo refractive surgery, but the pre-existing lysyl oxidase levels are on the lower side, they are at higher risk of developing ectasia, which has been published. Also, there are reports that even after doing a transplant surgery, there are chances of graft failure leading to progression of the disease, suggesting a genetic role in all of this, including lysyl oxidase. So our aim of the study was to explore if enhancing lysyl oxidase expression in corneal cells and tissues is safe and provides potential functional benefits relevant to keratoconus therapy. So ideal gene therapy is safe and non-immunogenic introduction of genetic material by an able vector, and which can overpower the functions of the defective or non-functional genes for therapeutic purpose. And the best way to do is AAV vectors. So we at our hospital have developed this vector production facility where we can produce the AAV vectors, and based on these AAV vectors, you can inject them for a genetic therapy purpose. Now, why AAV vectors? Because they are efficient delivery of genes to both dividing and non-dividing target cells. It has high levels of genetic expression, and it has absence of viral genes which is a potential of causing an undesirable immune response. And also, it doesn't cause any excessive toxicity or excessive immune response when delivered with an AAV vector. So our study was a 3-step study. The first was done in ex vivo cornea model, where one eye was treated with a GFP, which is a control agent with AAV, and the other eye was treated with lysyl oxidase, and 5 microliters of this saline vector was injected. So what we observed in the ex vivo cornea model study, that on injecting lysyl oxidase vectors, the lysyl oxidase levels increased. Not only that, it started increasing the levels of collagen 1 and 4, and it also reduced the inflammation. So there was a positive impact of lysyl oxidase, that it increased the collagen levels, which could be a reason how it will stabilize the disease. The second was to do on human corneal donor lenticules. So whenever we do a smile surgery, we would probably discard the lenticule. But here the lenticules were taken, and again one eye lenticule was treated with a control, which is the GFP, and the other eye lenticule was treated with a lysyl oxidase vectors. And the similar results were replicated were found to be in the donor corneal lenticule as well, that the lysyl oxidase and the collagen levels are increasing and the inflammation is coming down. So the third step was to see the different channels in cadaveric eyes, because at the end we have to do the gene therapy in human. So we used the intracorneal ring segment channel, and in one eye again a control was injected and the other eye lysyl oxidase was injected. And after 30 days we wanted to study the strength of the eye. So along with immunofluorescence, the AFM, which is to study the strength of the eye, was also performed. So what we observed here was that this is the control and this is the lysyl oxidase. If you can see, these are the collagen bundles, and you can see good spacing between these collagen bundles in a control eye. However, if you take a lysyl oxidase injected eye, you can see the spacing, which is the collagen bundle spacing, is reducing, thus telling us that the lysyl oxidase therapy not only increases the expression of lysyl oxidase, but also increases the expression of collagen, and it also makes it compact. And on AFM study, which is to see the stromal channels, what is the strength of the eye, what we saw was that on injection of lysyl oxidase, there was an increase in the elastic modulus compared to that of control, and this was a contralateral eye study as well. So corneal gene therapy can be effective. It's why cornea, because it allows a versatile methods like topical, mechanical, surgical, electrical and chemical way of injecting it. And not only we can inject it, but we also have imaging modalities like structural and biomechanical changes which can be studied in the cornea, which is quite effective. So AEV transduction of corneal tissue was safe, and a recombinant AAV-mediated lysyl oxidase therapy can be effective in cornea, can be safe and can be delivered. So lysyl oxidase augmentation does enhance the expression of collagens while reducing the MMP9, which is also a good thing because it reduces the inflammation. So it can be a potential therapy for keratoconus in future. Thank you.
We can have the judges ask questions for about 1 to 2 minutes and no audience questions.
A single dose is enough, and is the effect going to be sustained?
So ma'am, at this point of time, we do think that single dose will be enough. So this has been done on ex vivo cornea models. We have received approvals from the CDCSO and DCGI recently. So I think maybe in April or May we will be doing it on patients. So at this point of time, single dose should be enough. But the beauty of the treatment is even if you want to repeat it, you can repeat it because you're doing it through the intracorneal ring segment channel and you're not inserting any rings. So you can again open up the channel and inject the vectors if needed.
How are you going to follow patients? You see your first human trial is going to be in April about. Congratulations.
Thank you.
And how are you going to follow the patients?
So the follow-up of the patients is going to be day 1 week, 3 weeks.
Sorry, and how are you going to determine?
So we aim to do corneal topography scans, the biomechanical changes through the Corvus-ST model because it will tell us that because the lysyl oxidase and collagen is increasing, whether the strength is increasing. Because on AFM model, we have seen the strength is increasing, but we need to see, so which will be done with biomechanics. We do have a tool, a diagnostic tool in our hospital, which is a polarization sensitive OCT, which will help us see the collagen orientation and density in the thing. So we will be doing that. And for to see whether the levels of lysyl oxidase have increased, we'll have to do a tear diagnostic test. So all of this will be done as a part of the trial. Thank you.
Thank you, Pooja. The next presenter is Dr. Harsha. The presenter after that is Dr. Anshupa. So is Dr. Harsha here, please? Yeah. So Dr. Harsha Nagraja is presenting evaluation of donor corneas from deaths due to systemic malignancies for use in cornea transplant. Harsha, are you ready?
Yeah, right.
Okay. Please start the timer.
Good afternoon, everyone. So I'll be presenting about our study where we evaluated if corneas obtained from donors with systemic malignancies can be used for cornea transplant. So basically, when we looked at our eye bank statistics, we saw that we collected around 1,400 eyes per year for the last 3 years. But what was interesting to note was that our utilization rates were around 45%. The majority of the eyes were not utilized because of the poor quality of the corneas, for which we have no control. The next commonest cause was septicemia. We already published in 2016 that these septicemic eyes do not harbor any causative organisms and can be used for cornea transplant. The next third commonest cause was donor malignancies, and that brought us to a research question. That is whether these corneas which are obtained from donors with systemic malignancies, whether they harbor malignant cells and transmit the malignancy to the recipient, or are they safe for cornea transplant. So to answer this, we conducted a cross-sectional study where we included 48 eyes of 24 donors, and after obtaining clearance from the hospital ethical committee, we included donors with active solid organ malignancy with metastasis. Those with hematological malignancies and those in remissions were excluded from the study. We also collected the reports about what malignancy it was, what was the staging of it, what treatment was being collected to the patient reports, and we collected whole eyeballs here. And we studied at 4 degrees Celsius. And as soon as we got it in the clinic, we used 5 parameters to assess if there are any malignant cells in this. The first was by a trained cornea surgeon by slit lamp examination to look for any KPs or nodules which indicate tumor dissemination, and then it was sent to a pathology lab where it was evaluated by ocular pathologist as well as oncopathologist who are blinded to each other. They did a gross examination for tumor seeding, followed by a histopathological examination with HND staining and light microscopy, followed by cytological evaluation of the aqueous and vitreous was done, and this was followed by the immunohistochemistry where specific tumor markers were looked, and this is supposed to be a gold standard to check for any malignant cells in the tissues. And this is the grossing technique which we used. This was called the Breadloaf technique, which is commonly used for the diagnosis and grading of the ocular tumors. So this is coming to the results. Majority of the patients were males and the mean age was around 69 years. This chart here shows the various malignancies that we had in our study. Breast carcinoma being the most common, and also we had 3 cases of head and neck tumors. So this is a comprehensive table where it is showing the histological subtypes, the metastatic status, the tumors markers that we used for IHC. So to summarize this table, all the 5 parameters which we used did not show any evidence of malignant cells in them. Special consideration was given to while evaluating the various layers of cornea, the limbal region and the vascularis tissue. This is because this is where the metastasis can occur. And even the IHC was negative for any tumor markers, indicating that it is absent of malignant cells, and these corneas can be definitely used for cornea transplant without the risk of transmission of malignancies. When we looked at the literature, we saw that in 1981, Wagner et al. Had published a report where they had transplanted 86 eyes obtained from donor corneas to patients and followed them up for a period of 10 years. 8 of them did develop malignancies, but what was interesting to note was it was not the same as the donor corneas, indicating that this was not transmitted from the donor tissues and they are safe for transplant. Similarly, another Spanish group had transplanted 325 corneas and found similar one. There was no transmission from the donor to the recipient, indicating again safety of this usage of corneas. So how is our study different is that this is the first histopathological study and IHC, including IHC study, where we are showing directly that there are no tumor cells in the cornea. This itself indicates that these tissues are quite safe for transplant and do not transmit the donor malignancies. So, however, whenever there is a doubt, you can always use the peripheral corneoscleral limbs or the limbal areas for a frozen section, get the reports within half an hour, and then decide regarding the usage of tissues. So basically what we are telling is that we always correlate the eyes which are collected or donated with the prevalence of corneal blindness and measure the disparity. But what we forget is the loss of tissues because of non-utilization. This itself reduces the number of tissues which we already collected more and skews this ratio, and there is much more disparity in the when we calculate this for the corneal blindness. So what our study does is, through scientific proofs, we are trying to show that some of these contraindications might be outdated, this needs to be re-evaluated, and maybe try to conserve this precious resource that is the cornea to reduce blindness. And as cornea surgeons, it is imperative that we not only do corneal transplant but also work hand in glove with the eye bank people to increase this utilization of the tissues and reduce the socioeconomic burden of blindness. Thank you.
We have questions from the judges.
Can I have a question? So I might miss the introduction. So currently, what is the situation in Indian eye bank? So I'm wondering. So can you use the eyes donor cornea from the actually with eye person with a systemic malignancies right now in India?
No. We are not. That's the reason we did the whole study.
Okay.
Yeah. Right now. We are not using it now.
Not okay.
None of the institutes are using it.
Okay, thank you very much.
Yeah, it's just a comment because I am from Singapore, and the Singapore Eye Bank uses all these patients who passed away from systemic malignancies. We've been doing it for almost more than 25 years now. Yeah.
Right now. That's why we did talk to some of the institutes, but they're not using it, including our institute, where we saw that almost 15% was discarded.
We're also, I'm from US, and we've also been using them for years.
Not been using them?
So it's sort of a non-event where we are.
They use.
We use, yeah.
Oh, okay.
We've been using for
only
years.
Maybe in India. And,
So yeah, it's EBAA standard
Right.
is we use it.
Right.
So it's kind of a
Right.
non-event.
Yeah. Thanks a lot, Harsha.
Thank you.
The next presenter is Dr. Anshupa Patnaik, and after that is Dr. Ankit Agarwal. So Dr. Anshupa Patnaik. Are you ready, Anshupa? Just adjust the mic to you, please. Yeah. We can start the timer.
Yes. Good afternoon, everybody. So fungal keratitis, I do not need to re-emphasize the fact that it's the most common form of keratitis in our country, and why we are constantly after coming up with new things for it is because it's insidious in nature, meaning that the patient comes to us at a very late stage where the prognosis is pretty poor. The standard approaches which we have, like the smear culture, only provide a basic information regarding the species, the amount of damage, inflammation it may cause, the sensitivity to the treatment, the resistance which is caused by the medicines, and whether it will heal or not is still an unknown factor. Treatment-wise, antifungals has not been much of an advancement over the years, which is why currently there are 1/3 of the patients which remain refractory to treatment. Right now, there are no methods which are available to determine the contribution of the host response in corneal damage, which brings us to the present topic, that is proteome analysis, which is a promising new approach in understanding the host and pathogen effect and cytokine response in the tear. So my study is based on one of the previous papers which was published in our institute, where we studied the tear proteins from Aspergillus flavus positive patients, where a number of proteins were assessed in their tears. Many of the proteins were very highly upregulated in the acute phase, some of which were upregulated in chronic stages. Out of all these, we basically focused on 5 major proteins which were majorly upregulated and downregulated in their throughout the stage of keratitis. And this is just a proteomic workflow to show what all we used. We basically used 2D electrophoresis. The objective of my study was to examine which of these 6 tear proteins can be used as indicators of host immune response, to integrate this tear marker levels with clinical features to develop a model to predict the treatment outcome in patients. We took a total of 136 patients who were culture and smear positive for fungus and documented all the clinical features, which included the ulcer location, the depth, presence of hypopyon, and the presenting visual acuity. Based on how they were healing over a period of 3 to 4 weeks, we divided them into responders and non-responders, and an absolute quantification of these 6 tear proteins in the tear was done using commercially available kits. This is just a division of what all fungus we had taken, and it amounted to a total of 136. So there were, out of all the proteins which we saw in the acute and the chronic phase, out of these 5 proteins which we focused on, it was seen that the complement factor B by H ratio was indicative of an inflammatory response in all the keratitis patients. A calprotectin and vimentin ratio was an indicator of an ulcer which was ongoing, not healing, basically worsening. Calprotectin, vimentin, and complement factor B were high in cases where there was a large ulcer size or it was a centrally placed ulcer. A large hypopyon was directly proportional to the amount of vimentin which was seen in the tear proteins. And in non-responders, it was seen that the calprotectin by vimentin ratio was increased. Basically, what we wanted, there have been previous studies by Dr. Prajna et al. Where we now clinically can kind of sense, or we can kind of judge when a patient comes with a poor visual acuity, late onset, old age, or a large ulcer, that these are poor prognostic factors of an ulcer. However, when we use these clinical factors along with these tear biomarkers, our chance of predicting the treatment outcome of keratitis increases to about 92.3% as compared to 85 and 73. So concluding, my point in this study, our point was that the tear protein analysis can complement a physician's experience aiding in decision making regarding the need of an antifungal drug along with a host response modulator treatment. Implementation in clinical practice may help us in identifying which of these ulcers would not be responding to a standard antifungal and may need something more than that. A timely surgical intervention would also reduce the risk of infection spread and reinfection after TPK. Right now, what we lack is predicting which of these cases would not respond to an antifungal therapy. 2 patients with the same species, with the same size of ulcer, one responds to normal therapy, the other doesn't respond, ends up with a TPK. Which one does that? We still don't know, and why. Which is what brings us to proteomics. We need a treatment which is not only directed towards the pathogen, which we are doing right now, is we are focusing only on the pathogen and not treating the entire disease as a whole. What we need is a treatment would be directed to reduce the host cell damage and maintain the host cell homeostasis during infection. which is critical to prevent further deterioration in visual acuity. Basically, we don't need a blanket treatment for everything, but a more specified and specific treatment and a very patient-oriented treatment, which is what I intend to do with this paper. Thank you.
Thank you, Anshupa. Any questions, please?
For the same pathogen, have you found responders and non-responders with the same pathogen have different markers?
Ma'am, I didn't get your question.
If you have the same pathogen, okay, like Aspergillus or something, and you have two patients with the same pathogen, have you found one that's a responder and one that's a non-responder with
Yes,
the
ma'am,
same?
that's a very common scenario in our OPD that Aspergillus, not only Aspergillus, even if it is whatever species, there are patients who get healed immediately, probably in a period of 3 weeks, we see scarring along the margins. But there are patients who keep on increasing, either end up with a perforation or the infiltrate keeps on increasing, and we don't really know the reason why.
So you found a difference in the markers with the same pathogen in different patients?
Yes, ma'am.
That's okay.
How far away are we from looking at this as, in some kind of easily dispensable tool in which, you can just use in the clinic?
Ma'am, right now, this is at a very nascent stage. As of now, what we are trying is we've come up with a small probe to diagnose whether, for all the vision centers, it's a dye-based probe which will help just a general ophthalmologist to diagnose whether it's a bacteria or a fungus. It changes its color based on what it is.
Right.
So we've yet to reach to this level of being able to see which biomarker or which protein is increased. But I think in a period of 10 years.
Okay, all right. Thank you.
Thank you, ma'am.
Are any of the hall volunteers here? Hall volunteer? Can you please see if that music can be turned down, or can you please do something about the music? जो music है ना बाजू में उसको बंद करा सकते हैं क्या?
अंकित अग्रवाल.
So the next speaker is Dr. Ankit Agarwal, and Ankit is his paper is an innovative low-cost dry eye treatment. So can we have the presentation? Yeah, Ankit, are you ready?
Yeah. Yes,
please
ma'am.
go ahead with the timer.
Okay. Thank you. Thank you, AIOS, for giving this wonderful opportunity. The topic is innovative low-cost dry eye treatment. I have no financial interest in the product which I have shown here. So dry eye is defined as this function of lacrimal functional unit comprising of lacrimal glands, ocular surface, and its lids, sensory and motor neurons. So the most common type of dry eye which we encounter in our country is meibomian gland dysfunction based dry eyes, which is more appropriately termed as tear film dysfunction. Most commonly, MGDs are associated with diabetes and poor lid hygiene, and as we know, India is slowly becoming a diabetes capital of the world, so increases the MGDs. The treatment modalities available for dry eye range from topical lubricant drops like carboxymethyl cellulose to anti-inflammatory agents like cyclosporine and steroids. So various device-based therapies have come up in recent years like LipiFlow and IPL. The LipiFlow works by heating and expression of the meibomian glands, and IPL works by reducing the meibomian inflammation by an unexplained phenomenon. So these are the two machines which I am talking about. The problem is that these two devices are very costly. They range from something in the range of 25 to 30 lakh rupees and it becomes difficult for doctors as well as the patients to afford the therapy on a long-term basis. So only a select few who can afford these can possess the machine, and only a select few patients can get the treatments. So the purpose of this study was to describe the innovative low-cost dry eye therapy system as compared to much costlier alternatives which are available in the market. The study was performed at a tertiary eye care center north of India. Therapy protocol was designed where a low-cost heater cum massager, which is easily available online. I purchased that, and I designed a protocol to treat dry eye diseases, which is caused due to meibomian gland dysfunction. A data of 39 patients aged between 43 to 59 years was collected. Of these, 27 patients underwent therapy using this novel device, and 12 patients, the therapy was done using traditional method of warm compresses and massage of eyelids twice a day. So this is the eyelid massager which I am talking about, and this is the patient undergoing this therapy. So what happens is, this massager, it maintains the temperature of around 104 to 107 degrees Fahrenheit. That is approximately 39 to 42 degrees Celsius. and it has various massage points. That is, it compresses the eyelids at various points so that meibomian expression is done and the meibomian gland blockage based is reduced. The device is used for 15 minutes at a time and once every 3 days for 15 days. That is, a total of 6 sessions are taken. At the end of 1 month and 3 months, the following diagnostic checks were carried out. That is, Schirmer's test, TBUT, and OSGI score was taken at the beginning, after 1 month and after 3 months. All patients were prescribed 1% carboxymethylcellulose eye drops, irrespective of which therapy protocol they are following. The results of these 3 tests were compared and those from before the treatment. The results were that the low-cost device reduced the incidence of MGD at 1 and 3 months as confirmed on normal post-treatment Schirmer test and tear film breakup time. The traditional treatment group also had significant improvements, but lesser than the treatment newer device protocol. The patients in both were symptomatically much better from the before therapy as confirmed on the OSGI scoring. So this is the flowchart regarding this. So mean value of Schirmer's pre-treatment in the novel device group was 24.8 millimeters and the traditional therapy group was 25.3 millimeter. However, at 1 month therapy, the novel device group had reduced Schirmer's to 16.7 and the traditional method was 19.1. This increase in Schirmer's was in MGD is basically due to inflammatory reflex of the tears. At 3 months, the inflammation reduced further and the Schirmer's test came back to within almost the normal limit, 14.2 millimeter and 14.7 in the novel and traditional therapy. The T-BUT consequently increased. The mean pre-treatment T-BUT values were on an average 3.3 seconds, which increased to 8.5 and 11.1 seconds at 1 and 3 months in the novel device. And in traditional therapy, it came to 6.4 and 9.1 seconds. At 1 month of therapy, the patients who underwent treatment with the novel device had much improved Schirmer and T-BUT values as compared to traditional treatment group. At 3 months, there wasn't much difference between the two groups. So, this innovation is a low-cost MGD treatment alternative to devices which are available commercially and thus makes the therapy accessible to a majority of doctors and patients who otherwise would not be able to afford to buy them or pay for their therapy, respectively, due to financial constraints. Thank you.
Can I have a question? So you mentioned the improvement in OCD questionnaire.
Yes, sir.
So okay, what symptoms they actually improved best at the 1 month?
Yes, ma'am.
So what symptom?
The symptoms that which the patients definitely said that they had lesser pricking sensations, less feeling of dry eye, especially when they are driving. So less watering when they are driving. So these symptoms because I tried this therapy mostly with patients who are working. So they had their complaints were mostly when I'm looking at the computer screen, I'm having watering. When I'm driving, when I'm having watering and pricking sensations in the eyes. So these patients improved significantly.
Thank you.
Okay, thanks, Ankit.
Thank you, ma'am.
Good presentation. The next speaker is Dr. Vivek Nimje, and also requesting Dr. Divya to be ready for the talk after that. So Vivek is going to present his paper on role of anterior segment OCT in evaluation of fungal keratitis. Are you ready, Vivek?
Yes.
Yeah, please start the timer.
Good afternoon, everyone. I will be discussing on role of anterior segment optical coherence tomography in evaluation of fungal keratitis. Fungal keratitis is widely distributed fungal infection of the cornea caused by broad spectrum of filamentous fungi and yeast. It accounts for generally 30 to 40% of corneal ulcer in India. The clinical features such as dry looking corneal ulcer with feathery margin, intact epithelium with deep stromal involvement, satellite lesions, endothelial plaques. It is a sight-threatening condition. Normally, slit lamp biomicroscopy is the routine tool clinically used for the examination of fungal keratitis. It is difficult to measure the depth of corneal infiltration and associated corneal edema by slit lamp biomicroscopy. As a result, in vivo information about the corneal changes and tissue response to treatment is limited. AIOCT, it is non-invasive, non-contact imaging device. It provides the detailed structure of anterior part of the eyes. It quantitatively assesses the depth of stromal infiltration. It also measures the width of infiltrate and the corneal thickness. OCT can quantify the corneal changes which help grade the severity of the disease and assess its progression. Aim of the study is to assess the anterior segment OCT in evaluation of and monitoring the progression in fungal keratitis. It is hospital-based observational study of 6-month duration conducted in Department of Ophthalmology, Assam Medical College the 20 patients diagnosed with fungal keratitis were included in the study. A method of data collection, a thorough clinical history including age, sex, occupation, symptoms, progression was taken along with the general and local ophthalmological examination using slit lamp examination. Clinical diagnosis confirmed by cornea scraping in all the patients, and the samples was sent for gram staining, KOH mount preparation, culture and sensitivity. ASOCT imaging and clinical slit lamp examination were carried out simultaneously on day of presentation, subsequently on day 7, 14 and 21 of treatment initiation. A standardized scanning protocol was used for all the patients. Corneal thickness and infiltrate thickness were measured along with the axis perpendicular to the horizontal axis of the scan at the center of infiltrate in all the cases. During treatment, corneal perforation occurred in one patient. There was a male preponderance in our study. Corneal thickness at baseline was 644.8 micron at presentation, which then subsequently reduced to 596.8 at day 21. Infiltrate thickness was at the day of presentation was 396.2 micron, which then reduced to 323.3 on day 21. Infiltrate width could not be measured in all the patients because of limited scan size in standard spectral domain ASOCT. Thus, limbus to limbus image could not be taken with the help of ASOCT. The mean infiltrate width on day of presentation was 5.6, which decreases to 4.5 on day 21. Different ASOCT patterns were found in our study, such as epithelial plaques, epithelial defects, stromal edema, stromal infiltrate, stromal thinning, stromal cystic lesion, and endothelial plaques. These are some of the image showing the hyperreflective area with posterior shadowing. This image shows the endothelial plaques. There is a epithelial defect seen which shows maybe because of the drug deposition or pigmented area. This image shows the sloping edge along with the stromal thinning. This image showing the stromal cystic lesion, which is also suggestive of the necrotic area. Slit lamp biomicroscopy, it is a gold standard method for diagnosing and monitoring of corneal infection, but it has some disadvantages. It is a subjective method, and assessment of depth of infiltration is difficult in the presence of corneal edema. ASOCT is extremely useful for identification, measurement and monitoring of the size, age, margin of the ulcer. Also, the depth and extent of infiltrate and measurement of corneal thickness even in the presence of corneal edema can also be taken with ASOCT. Different ASOCT patterns such as epithelial plaque, stromal edema, corneal thinning, epithelial scar without epithelial defect, endothelial plaque, stromal cystic lesion could be identified easily, which is often difficult to be appreciated by slit lamp examination. Namrata et al. Studied the ASOCT in fungal keratitis. They measured the corneal thickness, corneal infiltrate thickness, infiltrate width on serial ASOCT scan. Corneal thickness, infiltrate width could be found maximum on day of presentation and decrease significantly with treatment on follow-up.
So your time is up, doctor. So you can stop here. This can stop here. No, because the time is up.
Yes.
That's how this goes.
Yes.
So if there's any quick question, we'll take that up.
How is this monitoring by ASOCT going to change the way you manage your patients?
Yes, ma'am. We measure the three parameters: corneal thickness, infiltrate thickness, also the infiltrate width. By also the in ASOCT, we can measure the signs of scars such as hyperreflective area with defined margins. That's how.
Okay, thank you.
Thank you very much, Vivek. Very nice. You must try to stick to time. So I'm sorry I had to be the bad guy over here. Very good. All the best to you. Just one announcement that all the presenters, yeah, you can come up if you're next. all the presenters to stay back because the one who scores the highest from this session will go straight into the finals of the Cornea subspecialty papers. So you need to stay back. So this is Cornea 4. So from 1, 2, 3 and 4, all the top rankers will be again going into the last part of this presentation. So Dr. Divya. Yes, Divya, please go ahead and start if you're ready. Start the timer, please.
Good afternoon, everyone. My presentation is on neem oil, a novel natural therapy for demodectic ocular surface disorders. I would like to thank AIOS and my professors for giving me this opportunity. I have no financial interest. Demodex is known as a common ectoparasite for causing human dermatological and ocular manifestations. Demodex follicularum affects humans and it most commonly resides in the hair follicles, causing anterior blepharitis, while Demodex brevis affects the meibomian gland, causing meibomian gland dysfunction and conjunctival congestion. Clinical symptoms seen in eye are anterior blepharitis, meibomian gland dysfunction, chronic conjunctival congestion, and keratitis. So far, there has been no FDA-approved treatment for the treatment of Demodex infection. However, literature has shown the use of many wipes, systemic drops, intense pulse rate, and a lot of medications. For the past decade, tea tree oil has been used as an extract, ointment, and lid wipes. However, the tea tree oil that are commercially available is most commonly seen in Australia, Europe, and North America for its broad antimicrobial property, anti-inflammatory, antioxidant, and wound healing properties. The wipes available are usually found more costly, which cannot be accommodated by the normal Indian. So we know about neem oil, which is known for its normal antimicrobial, antiparasitic, and anti-inflammatory properties. So in this study, we have studied with neem oil mainly because of its increased availability, decreased cost, and its lesser side effects. The aim of this study is to use neem oil and to show its effect of topical application for patients with ocular demodicosis, to show its effect on mite eradication. We included patients above the age of 10 years who had symptoms of ocular demodicosis and who had tested positive using microbiological confirmation. Patients less than 10 years who had other eyelid trauma or chemical injury or cicatrizing conjunctivitis and who were allergic to neem oil were excluded from our study. Patients who tested positive with microbiological confirmation were given a score. A score of greater than 5 mites per eye was considered as significant. Those patients were advised a topical application of neem oil along with coconut oil in a ratio of 1:1 as a face mask. They were advised to keep it for 30 minutes and then wash it off. They have to avoid contact with the conjunctival mucosal surface. Additionally, patients were advised eyelid hygiene and lid toileting along with topical lubricants and low-dose topical steroids for some patients. Patients were reviewed after 15 days and after 1 month. The primary outcomes measured were the symptomatic relief as reported by the patient and an improvement in the cylindrical dandruff. The secondary outcomes were measured were the improvement in the meibomian gland dysfunction, tear production, decrease in conjunctival congestion, and an improvement in keratitis. Out of 278 patients enrolled in our study, it was seen that males and females were equally affected and almost all patients had a bilateral involvement. Patients from the age group of 41 to 60 years were more commonly affected. Patients most commonly presented with blepharitis and MGD. However, patients also showed conjunctivitis, dry eye, and keratitis. In the first review, 232 patients, which is 83.5 patients, reported the improvement of ocular symptoms, which was comparable to the previous studies using tea tree oil in the past. The cylindrical dandruff, which is a main indicator of mite density over the eyelashes, in our study, 90.60 patients showed an improvement in the cylindrical dandruff in their follow-up visits. Secondary outcomes measured in that the conjunctival congestion and meibomian gland dysfunction showed a dramatic response with the use of neem oil. Keratitis also improved well. However, the dry eye patient showed a slow improvement. Out of 278 patients who had eyelid involvement, it was seen that 94.9 patients improved in our study. Out of the 124 patients with chronic conjunctival congestion which did not respond with any other medications, 114 patients showed improvement within 45 days. And 58 patients with corneal involvement were given neem oil therapy. 75.9 patients had improvement within the next 45 days. These were some of the patients who had a stable ocular surface in their review and the corneal lesions which were scarred. So now coming to the steroid use, in our study it was confirmed that patients with eyelid involvement and conjunctival congestion just improved with topical neem oil alone. However, patients with keratitis needed an additional low-dose topical steroid to show a dramatic response. Out of 278 patients, 2 patients developed toxic reaction and no allergic reactions were noted. So I would like to conclude that neem oil, due to its proven antimicrobial, anti-inflammatory and antiparasitic properties, can be considered as a good alternative for tea tree oil, especially in countries like India for the treatment of eyelid and conjunctival conditions, since it is easily available. However, further studies have to be done depending for the concentration and standard formulation of the neem oil that has to be used, and further study has to be done for its allergic and toxic reactions as well. These are my references. Thank you.
In your group of patients, did you have any patients who outright complained of unable to use the neem oil?
Yes, ma'am. We had 2 patients who had irritation and burning sensation after using, but they had applied it on the conjunctival surface as well. So after that, we started giving proper instructions, like they have to avoid any contact with the conjunctival surface. It has to be applied around the eyes and not inside the eyes like that.
Sorry, what concentration of neem oil was?
Yes, ma'am, that is the problem now. The concentration, there is no standard concentration. We have actually advised the neem oil that is available in our normal Ayurvedic hospitals. The more research has to be done on a standard concentration of neem oil, which can be safe for the ocular application.
All right. Thank you.
Thank you.
The next speaker is Dr. Afreen Bari, and after Dr. Afreen, it's Dr. Stuti Shah. Dr. Afreen Bari's talk his paper is Inferior Crescent Sign in Pellucid Marginal Degeneration. Are you ready?
Yes, ma'am.
Please start the timer.
Good afternoon, everyone. I am Dr. Afreen Bari, and my topic is Inferior Crescent Sign in Pellucid Marginal Degeneration. There are no financial disclosures. Pellucid marginal degeneration is a non-inflammatory ectatic corneal disorder that usually presents bilaterally and appears between 2nd to 5th decade of life. It is typically diagnosed on slit lamp examination and on corneal topography. On slit lamp examination, it is characterized by a typical inferior band of corneal thinning, which is around 1 to 2 mm from the limbus, and it extends from around 4 to 8 o'clock hour with adjoining ectasia above it. Corneal topography typically depicts a crab claw or butterfly or kissing dove pattern, which is as seen here in the third image. Now in our study, it was an observational case series where we did OPD screening with torch at a tertiary eye care center over 6 months. We found 9 eyes which were suspects of pellucid marginal degeneration based on the torch test. Confirmatory examination was thereafter done using slit lamp and sheen plug imaging. What we did was we asked the patient to sit comfortably and gave him a distant target for fixation. Thereafter, pen light torch was shown from superior quadrant with a torch at around 45 degrees from the horizontal meridian in this position. What we could elicit in our cases was that a bright, sharp crescent illumination was observed in the inferior region of the cornea and iris just above the limbus. This was seen. Now the patients with positive signs were considered PMD suspects. 9 eyes had positive inferior crescent sign. PMD was observed in all the patients, which was then confirmed using corneal topography showing the typical crab claw pattern. This is one of the representative cases where we can see that on torchlight examination the typical inferior crescent was seen, and on topography it was confirmed that the patient was having a pellucid marginal degeneration. The topography showed a crab claw or kissing dove's pattern. This is one of the atypical case where the crescent was formed anteriorly, and the patient on slit lamp examination we saw that the patient had PMD with healed eye drops. Now coming to the topic, as one of the other disorder of the spectrum, keratoconus, it is also an ectatic disorder and it is characterized by paracentral corneal steepening with thinning classically involving the inferotemporal central region. One of the clinical signs that is used in the diagnosis is the Rizzuti sign, which is also elicited on simple torch lamp examination. As seen in the image, in Rizzuti's phenomena, a sharp focus of light rays on the nasal limbus and iris is appreciated in the conical pattern when we throw the beam of light temporally. In contrast to keratoconus, the area of thinning and ectasia in PMD usually involve the inferior cornea. So we propose that inferior crescent sign as observed in the patients is due to deflection of the incident rays with a shorter focal length at the inferior corneal area of steepening and adjacent iris, illuminating the iris part and giving the inferior crescent of light. However, a study with larger sample size needs to be conducted to study the relationship of the grade of PMD with the type of crescent formed. To conclude, our sign, the inferior crescent sign, is a simple diagnostic sign for PMD which may be elicited in the outpatient department just with a torch without the need of additional equipments or even a slit lamp. And I would like to conclude by saying that in this era of continuous advancement of the technology, the simple clinical examination holds relevance. So this test will help us to screen cases of PMD. Thank you.
Afreen, have you looked at the false positivity and false negativity rates for this sign?
Ma'am, we did, after reviewing the literature, we did see that we might find false positive cases in cases of keratoconus, but however, when we tried seeing in these cases, we did not get such false positive. But we were expecting this to see, but we did not get. However, we need to conduct a larger study to find out.
Did you also check this sign with other corneal peripheral thinning disease such as Terrien's corneal degeneration?
Terrien's
corneal thinning degeneration?
Any signs?
Any signs of other peripheral corneal thinning disorders?
No, ma'am, we did not find such kind of clinical sign in literature described for other. Deciduous sign is a similar sign which has been previously historically described, but not with other ectatic disorders.
Okay, thank you.
Thank you.
Thank you, Afreen. The next presenter is Dr. Stuti Shah, and her paper is on combined corneal wavefront guided transepithelial PRK plus CXL. The presenter after that is Dr. Jayashree. So are you ready, Stuti?
Yes, ma'am.
Yeah. Please start the timer.
Good afternoon. My topic for today is combined corneal wavefront guided transepithelial PRK with CXL in mild to moderate keratoconus Indian patients. No financial interest. So we very well know that keratoconus is a most common primary ectasia, and it causes corneal thinning and protrusion of the thinned part of the cornea. So management of keratoconus involves inhibiting the ectatic progression as well as visual rehabilitation. So when a patient comes to us, we need to have a holistic approach. Corneal collagen cross-linking as of now is the only treatment available to inhibit the disease progression. But now the buzzword is something called CXL plus, wherein refractive surgery is done along with CXL. So there's a lot of literature in which they have done topography guided PRK with CXL simultaneously or sequentially, and they have tried to study the stability of the disease and progression of the keratoconus. In all of these cases, basically a surface ablation is done, and after that CXL helps in increasing the biomechanical strength of the cornea. In our study, we have done a corneal wavefront guided study on the Schwein MRS 500E platform. So the primary aim was to evaluate the visual and refractive outcome by doing this procedure. We have targeted mainly only the higher order aberrations, and the secondary outcome was to study the stabilization of the disease. So it was a prospective interventional study where 35 eyes of 31 patients had been studied in a tertiary eye hospital over a period of 1 year. Our inclusion criteria were progressive keratoconus of grade 1 to 3 with thinnest corneal pachy such that a residual stromal depth of more than 400 microns was obtained, and the logMAR CDVA was worse than 0. Exclusion criteria was any other previous ocular trauma or systemic or ocular conditions which would affect the disease progression, or patients who did not give us consent. So preoperative evaluation included corrected and uncorrected distance visual acuity, the anterior slit lamp examination, the topography scans were done. This is a representative image of a patient showing keratoconus, and the wavefront scans were taken, wherein higher order aberrations and coma both are visible to be raised. And after that, the fundus evaluation was done and the specular microscopy. So this is how the platform appears, wherein the corneal wavefront mode, all the data was entered and trans PRK was performed. The custom ablation manager itself targets only the higher order aberrations and tries to minimize the ablation depth, and finally gives us this summary with the ablation profile. It shows us the maximum ablation which is going to be performed. So the data was then put into the Schwein MRS platform, and the PRK was performed. It was a myopic hyperopic ablation, wherein at the cone the myopic ablation was done and a compensatory superior hyperopic ablation was performed. The optical zone was kept as 8 millimeters. After that, the C3R was performed using the Dresden's protocol. The post-operatively antibiotic steroid drops were given, and on post-op day 5, the BCL was removed after epithelial healing. Follow-up data was taken at 1, 3, 6, and 12 months, as shown in the table. So our results were that the mean age group was 20.16 years, 61% of the patients were males, and 54 microns was the mean ablation depth. There was no significant change in mean endothelial cell density. Uncorrected visual acuity had improved, however, it was not a significant change that was seen. The best corrected visual acuity went from a significant 0.4 to 0.27 logmar, which was a significant change. Maximum keratometry went down from 50.43 to 48.18, which was again a significant difference. Keratometric astigmatism also went down from 5.48 to 3.17, again significant. So did the manifest cylinder that the patient experienced, that is minus 2.5 to minus 1.65. More importantly, the higher order aberrations which we had been targeting. So the coma values went down from a 1.76 to 0.48. Trefoil also from 0.91 to 0.39, statistically significant. Root mean square values went down from a whopping 2.17 to 0.68. And the spherical aberrations also came down from 0.28 to 0.09. Again, statistically significant. So we could see that how this is the post-op image, and you can compare and see how the corneal surface has been regularized, and the higher order aberrations as well as the coma have come down, so did the trefoil. So in our study, we could see that there was a significant gain in BCVA and corneal regularity, significant decrease in higher order aberrations, and thus a better visual acuity was obtained mainly because of the decrease in coma. There was no progression noted over our study period of 1 year, and there was a significant decrease in manifest cylinder, which was comparable to other studies like the Gore et al. And Shaheen et al. We targeted only the higher order aberrations, so no secondary tissue removal was done for the induced ferrocylindrical changes, and ablation depth was also comparable to the Athens protocol. So in conclusion, corneal wavefront guided transepithelial PRK is effective in minimizing the higher order aberrations and thus provides good visual rehabilitation. CXL increases the biomechanical strength. However, we need long-term data. We need to have a comparative study, and patient perception also needs to be recorded in a better format. Thank you.
So what is different from other studies, Stuti, that you have shown in yours?
So compared to other studies, what they have done is they've used the topography guided model more commonly, wherein the keratometry, surface keratometry is used. Whereas in wavefront guided mode, what we are doing is we are targeting mainly the higher order aberrations. And also in other studies, they tend to either decrease the optical zone in order to minimize the ablation, because mainly in keratoconus, it's an ectatic disorder. We don't want to ablate too much of the tissue. So in this, we are targeting only the higher order aberrations. In that way, some amount of tissue needs to be ablated is also lesser. And our theory is that even if we don't get a good uncorrected distance visual acuity, the BCVA is better, and we can always give the patient spectacles or any other format later on.
Thank you.
Thank you.
We go on to the second last paper for this session, Cornea 4. So Dr. Jayashree Lilani, clinical outcome of large diameter PK in patients with anterior staphyloma. Are you ready, Dr. Jayashree?
Yes, ma'am.
Please start the timer.
Good afternoon, everyone. Today my topic is clinical outcome of large diameter penetrating keratoplasty in patients with anterior staphyloma. This is not moving.
Please start the timer. What's that? Okay, please go ahead.
Okay, so we all know as acquired anterior staphyloma occurs subsequent to corneal perforation, where iris plugs the wound and forms an ectatic cicatrix, leading to raised diopy and a painful blind eye. So the aim of any surgical intervention in such patients is primarily to achieve tectonic stability, and the secondary outcome is optical. There are different treatment modalities available for such patients, such as penetrating keratoplasty, mushroom grafts, sclerokeratoplasty, dural patches. However, we should counsel the patient that more than one surgical procedure in a stepwise manner may be required. There are several complications such as graft rejection and failure, secondary glaucoma, chronic epithelial defects, expulsive hemorrhage, choroidal hemorrhage, and phthisis. So the purpose of this study was to report the anatomical and functional outcome of patients with anterior staphyloma treated by large diameter penetrating keratoplasty. This was a retrospective study conducted at Cornea Department, SNC Chitrakoot, from January 2016 to December 22. The sample size was 43. The inclusion criteria: patients with anterior staphyloma without any active infection or inflammation were included, and the patients with loss of perception of light, congenital staphyloma, poor ocular surface, or any posterior segment pathology were excluded from the study. The preoperative details included detailed history, best corrected visual acuity, slit lamp biomicroscopy, digital tonometry, and posterior segment evaluation by B-scan. Intraoperatively, host size, graft size were noted, and or any other additional procedure done, such as pupilloplasty or iris repair, were noted. This is the surgical procedure. So peritomy is done using a conjunctival scissor, and a lamellar dissection is done. This further lamellar separation is further carried out using scissors, and then iris is gently peeled off to preserve the iris as much as possible. The anterior cynical lysis is done to release the pus, and then pupilloplasty is done in whichever patient as required. Now the graft is secured, and since there is a crescentic gap, it is filled with a graft scleral patch. So these are the post-operative and pre-operative images of the patient shown in the video. So post-operative evaluation was done at 1 week, 4 weeks, and 3 months. The parameters evaluated were BCVA, IOP, and graft clarity. The primary outcome measured in study was anatomical integrity, in which it was defined as adequate graft-host junction opposition, well-formed anterior chamber, without any graft infiltration, mending, perforation, thinning, or ectasia. And secondary outcome studied was visual acuity. So total 43 patients were included in the study, out of which 28 were male and 15 were female. The most common cause of anterior staphyloma in our study was heel keratitis. All patients had PL positive pre-operatively, and on digital tonometry, IOP was raised. Mean donor trepanation was 10.75, and the range was from 9.5 to 12. Cataract extraction was done in 6 patients, and pupilloplasty or iris repair was done in 35 patients. So at 1 week, 100% patients achieved tectonic stability. However, at 1 month, 2 patients developed graft infiltration, and at 3 months, 4 patients developed graft infiltration, along with 1 developed anterior staphyloma. And the IOP was normal in 96% of the patients. At 1 month, 84% had normal IOP, and at the end of 3 months, similarly, 84% patients achieved a normal IOP. So this shows the mean IOP at follow-up, where at 3 months, the mean IOP was 16.75. So BCVA in less than almost 56% patient had BCVA of less than 1/60, and similarly 22% patient had BCVA of more than 660 and more than 1/60. So coming to discussion, penetrating keratoplasty is difficult, but performing such keratoplasty is difficult in anterior staphyloma as due to forward movement of lens and iris diaphragm, and at times lens is strongly adhered to the iris, and so therefore careful dissection is done for salvaging the iris tissue as much as possible. In our case, we did corneal debulking to preserve the maximum iris tissue, and pupilloplasty was done for anterior segment reconstruction. Similar study was conducted by Manan et al., in which they studied 8 patients, and they achieved tectonic stability in all the patients. However, in our study, we had 84% patients achieve tectonic stability at 3 months. These are some other patients in our study. And glaucoma is a common complication seen in such patients due to floppy iris and pars formation. So using oversized graft by 1 mm and pupilloplasty provides an adequate anterior chamber depth. Pupilloplasty helps in forming a round circular pupil, thus preventing pars formation and secondary glaucoma. So coming to conclusion, even though we did not achieve a good visual result, the anatomical function of 84% cases was maintained in our study.
Thank you.
Thank you.
Just on time. Any questions?
Just a comment, because it's a very short-term follow-up you have on these difficult and complex eyes,
Yes,
right?
ma'am.
So it's very hard to make any conclusion from this study. So I suggest a longer-term follow-up.
Yes, ma'am.
All right. Thank you, Dr. Jayashree.
Thank you.
For this session, Cornea 4, we move to the last paper, Dr. Sonali Prasad, on individualized corneal cross corneal cross in ultra-thin corneas, cross-linking, I guess you mean.
Very good afternoon, everyone. My topic is individualized corneal cross-linking in ultra-thin corneas, the sub-400 protocol in Indian population. So keratoconus, as we all know, is a slowly progressive non-inflammatory ectatic disorder which leads to bulging and thinning of the cornea, leading to irregular astigmatism. Depending on the grade, it can be managed with the help of glasses or a transplantation may be required. So C3R is a procedure to stop the progression of keratoconus. In this, when the riboflavin reacts with UVA, it forms reactive oxygen species, forming the covalent bonds. So the Dresden protocol states at least a corneal thickness of 400 micrometer, which to prevent any endothelial toxicity. But this rules out a lot of potential corneas that could actually benefit from C3R. So options in thin corneas had been hypoosmolar riboflavin or contact lens assisted collagen cross-linking or a customized epithelial debridement. But all have had to have some or the other drawback. So in 2017, an algorithm was published by Sir Hafezi et al. To predict the biomechanical stiffening effect. And on this, they came up with a sub-400 protocol to find an individualized corneal cross-linking. A due permission was taken by Sir Hafezi et al. To use his protocol in our population. So our research question was, is sub-400 protocol effective in halting keratoconus progression in thin corneas less than 400 micrometer? So this study was conducted with accordance with Declaration of Helsinki, and ethics committee approval was taken. It was a prospective interventional case series conducted between July 22 to 23 December at Sadhguru Netra Chikitsalaya, Chitrakoot. So we included patients with stromal thickness less than 400 micrometer, and a progressive ectasia was defined as anterior keratometry or decrease in corneal thickness 10% in 1 year follow-up. Primary ectasia was taken in age group 9 to 19 years, and for non-electronic records, maximum K was taken to evaluate. The exclusion criteria was any patient with inadequate medical history or drug allergies. Frequency of assessment was done at preoperatively, 1 month post-op and 1 year post-op. We assessed the CDVA, refraction, biomicroscopy and demarcation line on ASOST with endothelial count. So the method of C3R was as similar as any other conventional method. We used Peschke-H hypertonic 0.1% riboflavin with Omni cross-linking systems, no financial disclosures. After doing the riboflavin soak, the pachymetry was done 3 times in the thinnest area, and average thickness was taken to find the duration of individualized radiation. So this table was given by Sir Hafezi et al., where he had coordinated for every stromal thickness what should be the duration, and according to that the demarcation line on which it would fall. We took a target of 70 micrometer demarcation line from the endothelium to keep a safety margin. Post-operatively, the patient was treated with moxifloxacin and steroids. The data was analyzed with continuous and non-parametric data. Coming to results, there were 36 patients in our study with 15 patients in 21 to 30-year age group. The BCVA was stable in around 30 out of 36 patients, and no significance was there in the pre and the post-operative values. The keratometry was stable in 35 out of 36 eyes with maximum flattening up to 1 diopter seen. Coming to pachymetry, the pre-operatively pachymetry in our study was ranging from 337 to 400, and intraoperatively post-op epithelial removal, it was 220 to 389. The demarcation line that was measured after 1 month on ASOST ranged from 210 to 378. This is a scatter plot diagram showing the relation between the demarcation line, and the orange line is the 70 micrometer safety line, and we can see around 11 readings were crossing the safety margin. This is another plot between the total energy and the time, and the demarcation line and the time, and both the graphs are not correlating with each other, thus denoting that the demarcation line was not actually following the algorithm. So these are some of the pre and the post-operative image of the patient who underwent the sub-400 protocol. Failure was seen in one patient in our study where there was increase in the keratometric values around 1.6 and decrease in the vision. Success was seen at around 35 patients and a 97% of success after 1 year follow-up. So this was a patient who failed on C3R having increase in the keratometric values. Coming to discussion, we have attempted hypoosmolar riboflavin, but the results show a difference in the increase in the corneal thickness during the hypoosmolar riboflavin. Then contact lens assisted leads to a decrease in the oxygen penetration. Customized epithelial debridement leads to a difference in the stabilized cornea and the thickness. So Sir Hafezi et al. Came with a sub-400 protocol where there was a success rate of 90% seen in his patients, but he commented that the demarcation line did not predict the treatment outcome, and it was unlikely related to the extent of CXL induced, quite comparable to our study. In our study, at 1 year post-op, the keratometry was stable in around 35 patients, no significant difference in vision, endothelial count was stable, and the demarcation line followed the algorithm to around 69%. The strength of our study is it is a prospective study of a long follow-up and a good sample size with endothelial status measured at post 1 year period. The limitations are 36% of the eyes are beyond the age group of 30, and we haven't assessed it below 14 years of age. No control group was there in our study, and it has not been compared with any conventional. So in conclusion, the sub-400 protocol was able to successfully prevent KC progression in thin corneas as thin as 220 micrometer with a 97% of success rate at 1 year. Thank you.
Thank you. Any question? Or
Why did you say that a limitation of the study was because 36 patients were over the age of 30? Why is that a limitation?
Ma'am, we could not use in the age group of 10 to 20, which is the maximum age where the keratoconus progresses. So most 36...
Well, I'm going to interrupt you for a moment.
Yes.
Actually, keratoconus can even progress even age 60
Yes.
or above.
Yes, ma'am.
So
Yes,
why
ma'am.
is it a limitation then?
We could not target the younger age group in our patients. So there were less patients in the younger age group.
Okay.
See, the envelope tha na uska cover. Acha, okay. So, thank you, Dr. Sonali.
Thank you.
We come to the conclusion of Cornea 4 session. I request all the judges to sign and date and finish up the scores. Don't total the scores, there's no need. And please, yeah, it's okay if you've done it, but there's no need. That